All right. Hello, everyone. Make sure, is my audio coming over?
Yes.
Perfect. Okay. All right. Well, here we are at the late morning, and I'm very excited to give this talk. This is something that lives in my brain a lot, and obviously it's related to patient care. But I think today you're going to maybe, I'm hoping to realign the way that the managers that are out there look at things, and also more importantly the staff. And let's I hope this we come away with a newer perspective. Okay, again, first and foremost, I want to thank the symposium for having me. I really love this. I love this every year. It's great. Everyone in the audience, thanks for being there. Otherwise, I'd be talking to myself. That does occur, and many other times. And again, everyone who's helped me over the years be a better perfusionist, a leader, and a person. And actually, my entire perfusion team, Team Perfect Perfusion, that they are constantly teaching me.
Tony, can you share your screen with us?
Team members. What's that?
Can you share your screen with us?
Oh, I'm sorry. I thought it was doing it. I apologize. How's that?
Perfect.
Looks good.
Oh, okay. Well, sorry, I just want to say again, thanks everybody. Is that better? Wonderful. Again, here's my wonderful team. And again, they teach me every day, sometimes the hard way, how to be a better leader. But again, I enjoy it tremendously. Again, taking care of business, no disclosures, and I'm a work in progress. Okay. I'd like to talk, here we are about the 50th anniversary last year, about Apollo 11. And since we're in Florida, we're not in Florida, but anyway, since we're in Florida, this Apollo mission here, that when they landed on the moon, that team, they traveled 477,000 miles, almost 478,000 miles. The average person drives about 14,000 miles a year. It would take you 35 years to do this. Okay, they operated a piece of machinery that was hyper complex, state of the art, yet you could see the multiple possibilities of things that could go wrong. Turning one switch at the wrong combination, piece of metal. Unfortunately, we've had the Challenger disaster, but all these things that could go wrong managed to go right. They went to the moon and they came back. But unfortunately, Neil Armstrong died after heart surgery. So he went to the moon in the most rudimentary or state of the art, depending how you want to look at it, but came back and had a complication after heart surgery, which if you read there was because they removed the temporary pacing wires and he bled to death. If you read into it a little bit more, and it is a little sketchy, that they don't really talk about everything that happened, but basically they didn't have a procedure in place. And the bigger thing, there wasn't communication across the team. You've seen this book here, To Err is Human, from the Institute of Medicine from 1999, and say 98,000 deaths annually in hospitals. But the thing to point out here, most errors are system-based and not due to recklessness. Modern Healthcare put an article out that says that 20 years later, we're still falling short. Joint Commission, it's the leaders' failures to create a safety culture. But why does this keep happening? Einstein told us, right? Insanity is doing the same thing over and over again and expecting a different result. I don't know if he really said the other quote, which said, sometimes you can't solve the problem with the mind that created it. And that's something to think about too. But really, this keeps happening. We have to change our perspective. Sherlock Holmes said, what remains after you eliminated everything is the answer. So there's a couple things that we haven't done or haven't looked at or one particularly. We focus on our quality and our outcome, but we don't focus enough on our leadership. And in the end, this is the care of a patient is the most complicated production process out there, because it's individualized care that's being driven and pushed to be done at a cost minimal basis. So I ask everybody out here to reframe their minds. And this is something that traditionally we all are brought up with, the idea that the boss is the one that tells everyone what to do. It's really the opposite. The leader should lead. The leader should help the team get to where they got to go, clear the path, share the vision. The team will only do what the leader cuts the path for. If you don't give the tools for the team, they're not going to succeed. That's the leader's responsibility. I spoke last year about Team Perfect Perfusion and talked about high reliable organizations, and I talked about and also having a highly accountable manager for the outcome. But here is something for everyone to think about, and this is the change in perspective. When I taught the leadership courses, Intro to Leadership course, there was a book that I used, and I suggest everybody read this, is Patients Come Second. For most people, that could be very shocking to hear and say, what do you mean the patient's first? No, and I'll give you another example that most of us are exposed to, maybe not in recent events because of COVID, but many times, and I'll give this to you in a second here. But so the leaders must create exceptional teams. They got to find ways to engage the teams, and they have to connect the employees to the work, but they also equip them to be tools to become better leaders themselves. And when you do that, patient care will change. MUSC has been working on creating an environment and a culture here of high reliability. It's very complicated. They've worked very hard on it year on year. They do a lot of investment into their leaders and their staff in terms of telling them where we're going to go. They conduct town halls. They have newsletters. They are very engaged as a leader, the higher leaders in the organization. But why is this all important? Again, a slide from last year that I used at the conference, but I liked it, so I brought it again since if you think back about it, with everything that's happened, a year ago we were worrying about Game of Thrones coming out. But a storm is coming. There's going to be a new healthcare environment. We're on it. We're all taking care of it, right? We've been doing this for a long time. And if you look at here, was a statement that said all hospitals are accountable to the public for their degree of success. And if the initiative is not taken by the medical profession, it will be taken by the lay public. Good statement. It was 100 years ago. So what's the solution? Right now, the way that where we're heading in healthcare is to create value-based care, not to get into it too much, but it's basically to create value, you have to have high quality over cost. The direct costs and indirect costs are where we're going to focus a little bit more today on how to keep our costs down and deliver the good quality. Just a quick little schematic of value-based healthcare and where the benefits are. And better care efficiencies is what we're going to be talking about for staffing. And again, I want you to keep your mind open. We're not trying to say do more with less. Because definitely in the future here, you're going to either be on the table or you're on the menu. At the table or on the menu, excuse me. You have to show that you're helping. So Dr. Culligan gave a great talk, and it's a great article, and I highly recommend everyone, managers and staff, to read it. And there's multiple factors inside that article, but one of the things that brought up is maintaining full staffing focuses around work-life balance. Pay is important, and other factors are also important, but work-life balance is very important. And that goes both ways for the employee and the organization. But it shows also from the research that it's a big area. So if you can impact that and stay on that, you can have great success as an organization. But let's talk about what happens if you don't solve that problem. Professional burnout. It's a chronic state of mental, physical, and emotional distress resulting from prolonged exposure to work demands. Professions with higher risk of burnouts, professionals in healthcare, teaching, policing, sleep disturbances, eating disorders, emotional instability, interpersonal conflicts, alcohol or substance abuse. Here's some perfusion specific studies on burnout that were done, and I recommend people go and take a look at these. They're pretty spot on. I think, not to say that we are all fighting some level of it, and I would love to give a talk specifically on these articles, but we have to be aware about burnout. Even in the light of the COVID right now, it's really added a tremendous amount of stress because we're worried about the patients that we care for, of course, first and foremost, but we have pressures at home. We're worried about our children because they may not be in school. We're worried about our economics if our own salaries were cut, or if the team was furloughed, or our spouses or partners have been laid off or furloughed. There's a lot of stress here right now on all of us, and we have to take even more steps to make sure that we can stay and deliver for that patient that still needs us as if nothing else was going on outside the world. It's a very tough time. And as I communicated with my staff, there's a time when you're doing a case, we've all been there, and the case gets really rough and you have to bring out your awesomeness. Right now, you have to bring your awesomeness out for yourself and for your family, and of course, again, for the patient. We'll get through it. So cumulative findings: excessive job demands have the greatest impact on burnout, stress level, conflict, reduced job satisfaction. 38% of perfusionists are in the high burnout category. Fatigue and acute sleep deprivation is a significant safety concern in the perfusion community. From a 2010 study, says they're showing some difference of how well they manage excessive fatigue in individuals. These are things that, as a manager and a staff, you have to work together on to make sure that this does not become a problem. So what are the costs of employee turnover? The reduced quality care, reduced morale, loss of productivity, increased workload, cost of the new employee, and you lose your historical knowledge. That's very important. Someone that's been there for a long time, and then you lose that. That is a big loss to the department. And then vacancy costs, which made John Johnson Foundation said that the cost could range anywhere from up to 20% of a perfusionist pay to get them replaced when you add up all the costs, indirect and direct. Did we lose something? Are we good?
Tony, you're going off and on a little bit with your connection. Okay. I don't know if you're Wi-Fi, but right now
you'll need to reshare your computer now.
Okay, sorry about that. I don't know where we fell off. But this shocking cost of turnover in healthcare is a little bit older article, but they even suggested an annual retention bonus of 33%. I like these people. But this could be a method to help keep people from having vacancy. Okay, we all get it. We've all been there. We need to have the right number of staff, but how do we get to a given environment with the lower volumes and increasing cost pressures, if we want to argue that they're lower volumes? We have to approach and understand that burnout's ever present. Turnover has negative direct and indirect costs, and some fall right on the patient. We need a sophisticated approach to calculating staffing, and we must be able to communicate this up. You have to manage your administrator. Again, we're going back to Dr. Culligan's, again, just to remind everybody about the focus on work-life balance. It is complicated. This is the model that MUSC works on. They try to create, in that article that I gave you, that there is a safety culture. They have a performance employee engagement. Like Conliff, it's been out since 2007, and I don't think there's been anything that's looked at this again in the past. I mean, has looked at it recently, but the concepts are solid. And so they looked at what are the factors that determine to determine how much staff you need, and which of these factors, because they are which ones are higher in their validity. Number of cases, on-call requirements, number of if you look at these ones, and then financial, so you could start saying that these are factors that you have to add into it. And it's not the number of cases. For example, you could say, oh, I only do 10 cases a year, so I don't even barely need one perfusionist. Well, if there's 10 surgeon operating rooms, you need 10 perfusionists. Sounds kind of obvious, and I'm being absurd to show the power of how these work together, and how you have to really look at them and not just look at one single item. All these have to examine it into your own place. It's specific to each hospital. We are in a war. We're in a financial war. We're in a quality war. We're in an outcomes war. You have to know your enemy, and you have to know yourself. You have to know and not fear. If you know yourself but not the enemy, you will suffer a defeat. If you know neither, you'll succumb in every battle. And we're in a battle. So back to this, you must take care of your employees.
Hey, Tony. I apologize. We're having a lot of technical difficulties. I think it's on your side. Would you mind if we just take a 5-minute break and maybe relocate your presentation or your talk, and maybe we can continue?
Okay, everyone, I'm back. Sorry for the technical difficulties. Again, and I don't know if where I left off exactly, but I wanted to say, for those who we've flown on an airplane, and they say if you're with a small child and the cabin pressure drops, the first thing is to put the oxygen on yourself and then take care of your child second. This is really the basis behind this book, from at least the concept of it, is we have to take care of the employees. We have to. Okay, so back to the the art of war. Excuse me, I bumped that. You have to know your enemy. You have to know the work. But one thing to make clear, again, I'm speaking to the staff perfusionists as much as the managers. We have to know the difference between workload versus workflow. There is a difference. Knowing about your practice will help you determine the right amount of staffing, and it will improve work-life balance. For example, workload, common things, how many cases? But do we look at what types of cases? Have we looked at how often, what is our case mix? Has it changed much? Has it, when do they occur? Did we lose, in our hospital, we have operating room block time. It's not like the old days where you just had 3 cardiac rooms sitting open and they filled them whenever they wanted and they flipped into them and everything. Now each surgeon has a certain amount of OR block time, because if that OR is not being used by the heart surgeon, they're going to put a different case in there. So we have to find out, again, they may let a surgeon do 2 cases a day, but it's no longer a flip into the second room. It's a follow. That makes a big difference on staffing. So just looking at the number of cases and saying, oh, your number of cases haven't changed. Well, you have to look at that and say, well, all of a sudden now we used to finish, at 4:30, 5 o'clock. Now we're finishing at 7:30, 8 o'clock. Well, when you talk about work-life balance to a perfusionist now, all of a sudden, if you have one perfusionist there, that's a 12-hour day. So as a manager, you have to argue backwards to your administrator and say that I'm trying to have work-life balance for my staff. You don't want turnover. You don't want errors. So we have to find a way that we may need more staff. Yes, you're getting the efficiencies out of the operating rooms, and those efficiencies may be coming because now in that other room that you can now do eye surgery or back surgery, some of that cost has to be transferred back because you may have made more money on the front side by doing more cases, but you've added a cost that is many times indirect. That indirect cost has to be paid for by that other surgery so that you can up your staffing levels, so that you can keep the work-life balance appropriate. When they occur and how it is very important. It's just a very big factor. How long are they? Are the cases changing? Does it take more than one perfusionist to complete? If you start saying, oh, we're opening up a VAD program, this is wonderful. Well, Laura Del Ria just talked about how many times you need 2 perfusionists. We're talking about the ANSEC standards and guidelines. The guidelines right now saying for the N+1 model. All these things are adding into the challenges. We have to communicate that to our administrators. In 2018, the Society of Thoracic Surgeons gave an update on outcomes and quality. So when I'm talking about knowing your enemy, I'm going to give a little bit of a snapshot of what we think is happening, because they give some data about the types of cases and the characteristics of the cases. And I'm going to just give you this for an example. We can see that isolated CABGs have not changed much. And again, I'm not going to dive into all this. I just wanted to show you that this article is out there to help guide you. Here's an interesting thing that has shown, and I think we all can relate to this, about what's happened between AVRs, TAVRs, AVR CABGs. One of the things that has been happening is aortic aneurysms are going up. Probably true in everybody's centers, not just a few centers. Well, these are long cases. These are high resource consumable cases, from human factors to all the other factors. This is a big challenge. So again, here's some volume trends, more tricuspid procedures. Well, you could say, okay, yeah, that's going up. Well, that's probably lengthening your case by another 35, 40 minutes if they're putting a ring in there or whatever. We can also see MVR CABGs going up. Yeah, we've had a drop here in MVR repair and CABGs, but we can see that the numbers of procedures are all going up. Again, if you go and look at the tables for how much they have gone up, you would say, well, the numbers are going up slightly. That's expected. But here's one part where it goes that has changed. Look at the complications. The elective the patients are increasingly becoming more and more diabetic. We know that. That's a complication. The elective status is actually going down. That makes it more challenging. There's less cases at 7:30 in the morning starts. All of a sudden you say, oh, we still are only doing 2 cases a day. Yeah, but both of them started at 11 o'clock. So things are changing. Congestive heart failure is on a rise. Again, these are the patients that we're working are sicker, and they're coming at us at different times of the day. We all got into perfusion knowing that heart surgery did not care about the clock nor the calendar. But at the same time, it's happening that we're seeing things highly variable. And again, here we go saying that's right. this is great. Thanks for the external world. You have to know, and this is where I'm at. This is the purpose of this talk too, is to say you have to know your center. Right tools for the job. One of the things that I was able to do is to get our information systems people involved. And there's a program called Tableau, and Tableau can access multiple databases. And so the staff and we met with one of the people from there, and we told them like what were the things we wanted to look at. I had the staff involved so that they would be engaged about what things are going to be important for us to monitor to know how well we are doing. And as you can go through here and you can see there's time periods we can adjust it. I can adjust it by time of day. I can look at case durations. I can filter it by any day of the week. I can filter it. I can look at the room numbers. I can do it by surgeons. I can even do it by procedures, although that's pretty extensive. I can look at by the perfusionist. And even in this one I'll show later, I can drop down and I can see the number of cases and what percentage starts at 7:30, what cases start after 9 o'clock, what cases finish past 4, what cases finish past 7 p.m. And it's all these factors, and I'll show you that go into my processing of how many people we need. Again, I blanked it out just for not get into necessarily the numbers, but just wanted to show you that I can look and see the number of cases by day of the week. And I can look over 4 years, 2 years, 4 months, 2 months, 2 weeks. And I can look at the trends about what's happening, and I can find out, hey, how many cases are we doing on Saturday? How many are we doing on Sunday? Which is our busier day? And I'll tell you how I use that even for other ways that we run the department. Again, I mentioned how I can look at case completion. We can see what percentage of cases. You can see here that 19, at least for this little slice in time, 19% of the cases are finishing past 4 o'clock, but only 6 go past 7. This tells me, you know, I can now look at, this helps me make decisions on my staff. Again, here's even a more robust, more granular way of looking at. So there's some cases, yeah, they start, you know, before 9 o'clock, and then but they go past 7 o'clock at night. Well, let's hope this number is low. Those are big cases, obviously. Let's hope. But so sometimes we look, okay, here cases at 9, started after 9, so that could be a to follow case, but still finishes before 4. That's pretty good. But I can also look at this and say, hey, the large percentage of our cases are to follow cases now. And that's happening. That's happening. I mean, that is really happening a lot. The good part is that they're finishing. But all these things help you make a decision to, and I will say this respectfully, if an employee says, man, I'm really working late this week, or something's going on, or something's changed, I can dig into these numbers and we can start looking at it. The other thing that I can look at is cases by days of the week. I can look at the average cases by days of the week, and I can look over the fiscal years and see, have they changed, or have they been the same, or is something different? The other thing, this has been really big for us, is looking at the case duration in hours. I want to tell you that our 5-hour cases are going down, and all these other number of cases have gone up. And I've shared this with my administrator currently, that the length of the cases are increasing. We even can look at cardiac surgery minutes in the operating room, and sometimes I do that just to look and see if there's a particular change. But again, all this helps me figure out, is it something that's just happening, or is it really real and it's been going on for a while? So again, knowing the enemy, not saying the perfusionist is the enemy here, but you have to look at what are the hours per week for CCP. You have to look at the cases per year for CCP. What is the rate of call? What is the call-in rate? What is the call-in rate on weekdays and weekends? All these things have to make you look and evaluate what is right and what is to get the job done, and do we not abuse our employees? We cannot stop that a case is going to happen at 8 o'clock at night. It's going to happen. How often it happens is something you should watch, but you also should have a staff in place, because that patient coming in at 8 at night deserves the same level of care as the patient that's coming in at 7 o'clock in the morning. Anything less than that is not fair to that patient. But you have to find a way to communicate that to the administrators so that you can get the right number of staff. Again, this is how I look at the utilization. I can filter by the perfusionist, and I can filter by the surgeon and location. And I can, when I click, say I pick myself here, I can find out how many cases I've done in the last whatever time frame. And I can see, oh, this is not a big deal to say, oh, I've done more Friday cases than Mondays, but it does at least give you an idea of what's happening. Predictability and work-life balance. I've talked to my staff many times. If you want to minimize your hours at work, you're gonna have to be flexible. If you want to have some consistency and predictability, you're probably gonna have to come into some kind of a structure. And there may be times that you're having some downtime, but you have to decide, do you want the predictability so that you can plan and so that you can be able to go to the dentist or whatever you need to do, or even know what time you're going to get out of work within reason. If you do that, then you have to commit to a structure. If you want to do it every day, just everybody show up at 7 o'clock and start peeling people off, that's fine. But again, I think that's work-life balance. More and more what I've heard, and not speaking just from my staff, but from all around with people, is that I don't mind if I work 10 hours versus 8. If I just know what 10 they're going to be, it's more valuable, and I'll even work harder. I think that's true for a lot of us. We are in a job that has unpredictability as its middle name. So a word about call, and I'll put this out there for people just to process. A lot of places do call day at a time. We do call week at a time. I know this looks very busy, and I'm not going to dive into it. But one of the things is that we cycle our call on a regular regimen. A lot of places do their call, they let their vacation determine when the call happens. Here, we work really hard to let the call happen on a regular basis, every 4 weeks, every 3 weeks, every 5 weeks. And that way, a perfusionist can know a year from now when they're on call. And then from there, we cycle through it. We also do a week at a time call, which allows us to have a perfusionist available for the evening, but at the same time, if they work through the night, they're resting during the day. A day at a time call, that's a pro and a con, of course. Day at a time, sometimes you get stuck with that long case through the night, and then you end up staying there through the morning, and then you're going home at 10 o'clock, and you have to turn around and come back. It doesn't work for us. I'm sure it works for other places, and I've been in systems that it did work. I've just found that it's better to fall a little bit into this regimen. People can predict what's going to happen to them almost on a monthly basis, short of people adding vacation. And we can kind of say, hey, for example, somebody just coming off of call will say, hey, I'm at the first morning spot. I may end up working late, but I know I'm the first one out the door. And I know we all have some kind of version of that, but I've just found the week at a time call works. And if you remembered back that I looked at by days of the week, we actually change our adult and pediatric call on different days, because on Wednesdays for the adult world, we do a bunch of TAVRs. And then on the, so on the adult side, on Thursdays, we also get the faculty come over. You can see here's Laura and Dave. And so that gives me an extra body. So that's the day that this person comes off a call, and then they can have a pager day where they can, hopefully we won't use them. All I'm saying is we set up a little bit of a structure. It is a little bit regimented, but at the same time, it gives them the predictability. And I think that contributes a lot to work-life balance. Another thing that I want to throw out there, I've given a talk on this years ago, and it seems to be working its way back in. Medicare has done the severity adjusted DRGs. So what they do is they look at, depending on if they have patient has complications or multiple complications or catheterization, they give different amount of money for a case. So a CABG is not a CABG is not a CABG. There's different money attached to that. If you can access this data at your hospital, you could find out that, hey, all of a sudden, here's our certain mix of patients, and that can give you a baseline of what your volume, what your revenue is for the hospital. And since Medicare has done the work, you can turn around and you can say to the hospital, hey, the next year your severity of cases went up, even though your volume went down. You made more money. Some of that more money that you made ought to be diverted to add more perfusion staff. And when I gave this talk, the thing that I was saying is how you could go to the administrator and said, caseload went down, but we need more perfusionists. Well, that's kind of happening now all the time. But it's this severity adjusted DRGs that can help you. There is revenue attached to this, and they know about this revenue. So you can use this to help you justify or maybe not get more staff, but make you know that you've made the right decision for your organization as well, to be financially responsible. So here's some take-home points. Burnout's ever present. The patient comes second. Of course, they're first. It's always about patient care, but you can't forget the employee. You can't. Turnover has direct and indirect negative costs, and some of them fall right on the patient. They do. Employee engagement is key. Survey your employees. MUSC does a really good job at surveying. Meet with them, talk with them, and listen to them. They'll tell you what needs to be done. Get the data. You need the data to make good decisions. And you need a sophisticated approach to calculating staffing. And you got to be able to communicate this upwards into the staff and manage your administrator. One of the things that I do is I share this data with our staff, with the staff, and we look at this in intermittent periods of time to see how well we're doing. Sometimes our perceptions and realities are different. We're all human, but at the same time, we're numbers people. So we like the numbers, and the numbers help us make decisions. In conclusion, leadership is the single most important factor for a team's performance. And all you have is your service. Thank you.